I received a phone call. So I'm a pharmacist working in my hospital at Petri, and I received a phone call from my patient saying, "Fam, where are you?" And I responded, "I'll be in the hospital by 9 a.m. Please meet me there." So I arrived at the hospital by 9 a.m. and I met a female patient waiting for me. And she said, "Please, ma, I need to see you. My husband has collapsed." And I was completely shocked by her statement. So I invited her in. I told her to sit down, and I told her, as step one requires, I'm a pharmacist. You can trust me. When I ask you questions, please respond. Every answer you give is for your benefit. I will see what I can do to help you. By doing that, I was able to establish trust and let her know that whatever information she's giving me, she can trust me because every help I'm giving is for her own needs. And I brought out a pen and paper ready to jot down all the information that she gives me, which is documentation, which is very important. And documentation begins from the start, from when you see the patient. So as she started speaking, I was able to jot down the subjective and objective data. She told me her husband is 61 years old. He I asked her the job and she said he's the businessman. He smokes, he drinks greater than 20 units, and you know that 1 unit is equals to 1 ml of pure alcohol. 1 unit is equals to 10 ml of pure alcohol. And she said they have done a lot of tests on him, lab tests, liver tests, and all those things are normal. So I asked, so what happened that he collapsed, and what have you gotten? There's some results. So she gave me some values that when they took note of his beats per minute, he had 175 beats per minute, which is an indication of tachycardia. And then when they took note of his respiratory rates, he had 25 breaths per minute, and the normal value is between 12 to 20. So that could have been a reason why he had shortness of breath, which is also part of the issues that he had. And then also hypertension. He had the reading of 100/70 millimeter mercury. And you know that when a patient like that has hypertension, the perfusion is going to be low. That could have also been a reason why he collapsed. And then also he has been diagnosed with hypertension earlier, 5 years ago, and he was given lisinopril, but then he wasn't really taking his drugs. So you know that your BP can fluctuate when you are not constantly taking your drugs. So that could have also been a reason why he had that reading for the blood pressure. And okay, so now other symptoms of atrial fibrillation, which is the diagnosis that was given for this condition, is fatigue and weakness. Then another sign that can be gotten on investigation is absence of discernible, consistent atrial activity. When the ECG was carried out, the ECG, the electrocardiogram, so you know that there are many points. So upon that test being carried, you notice that there was the absence of an irregular P wave, and there was also a rapid and irregular QRS rhythm. And another symptom he had was palpitation and shortness of breath. So the next thing after that, based on our pharmaceutical care steps, is to evaluate drug and health related problems. Since the only drug that we know of at this moment that was administered to him is lisinopril, we don't really have enough information on that to carry out the evaluation. But from step 4, my colleague is going to talk about the next.
Alright, so step 4 of the pharmaceutical care plan, we're supposed to develop and implement a pharmaceutical care plan. And the standard guideline that we are using for this case, everything I'm going to say is quoted from the guideline, is the 2023 ACC ACCP HRS guideline. So according to the guideline, your care plan must include 3 steps. The first one is optimizing modifiable risk factors. The key word here is modifiable because factors like age, gender, even height contribute to the incidence of developing atrial fibrillation. So the modifiable ones that we can get from these patients is the cigarette. The guideline says smoking cessation, no minimizing, no nothing, just stop the smoking. Then alcohol, you either eliminate it or you minimize if you cannot eliminate totally to less than or equal to 3 units, 3 standard drinks per week. That's if you are using rhythm control method. We'll get to that in a bit. Then, because we did not take his weight, we don't really know if we don't have his weight, we don't really know if he's obese. But if he's obese, a 10% weight reduction can help him. And then optimal blood pressure control is also a way to optimize the risk factor. So the next step is stroke risk assessment and treatment, if applicable. There is a system, should I say an algorithm for assessing the stroke risk of a patient. It is the CHA2DS2VASC score. So what that means is chronic heart failure, age, atherosclerosis, diabetes mellitus, stroke, vascular disease, and sex. So according to this algorithm, each of those factors has a point. So I tried calculating the risk for these patients, and the score was 1. That is very low risk. And the guideline says you only start oral anticoagulant prophylaxis if the score is greater than 2. So as at this point, we will not initiate that prophylaxis. But if maybe other members of the healthcare team who are more experienced insist, then maybe we can go with 75 milligram aspirin just to be on the safe side. Then the last step, we do symptom management using rate or rhythm control strategies. Now I'll differentiate between rate control and rhythm control. In rate control, the sinus rhythm remains altered, but then you try to reduce the heartbeat to a reasonable point. And then in rhythm control, you are trying to